What happens when somebody has a stroke and they're out in a rural part of the country? The local community hospital or critical access hospital has no neurologist on site. What are the options? Well, we can get the provider to see that patient, make an assessment, and set up a treatment plan with the patient in place in that existing hospital through telehealth effectively.
Mark, thank you so much for hopping on today's podcast. For the audience listening, we have Mark Noble on, CEO at ViTel Net.
Thank you.
Yeah, thanks for hopping on, Mark.
You bet. Pleasure to be here, Bert.
So first, Mark, what led you and your team to launch ViTel Net, and what problem in virtual care stood out to you guys early on?
All right. So first of all, ViTel Net is a company that got started in 1990. Our founder and original CEO was Alan Azadpina. He saw an opportunity for digitization in healthcare that hadn't existed in a meaningful way prior to that. So ViTel Net was actually one of the very first companies to provide virtual care solutions. And the company got funded by Congress in the early 2000s to study telehealth continuum, brought forward really cool solutions across the board for both the Department of Defense and Department of Veterans Affairs. The home run hitter was a remote patient monitoring solution. It was before iPads existed and tablets were a thing, so there was actually a manufacturing component to that. In 2009, we transacted that manufacturing component to the Robert Bosch Company, who became interested in the space. At which point, Alan took the proceeds and reinvested to build out what we have today, which is the vCare Command platform. It's a cloud-based virtual care work and data flow platform, effectively. And the challenge that we were looking to solve for was basically efficiency for the providers in being able to deliver care into places where people otherwise did not have access to that care. That was key and part and parcel to our mission in getting people access to the best care available. So very much provider to provider type of an approach. I'll share with you a story about telestroke. For anybody who's unfamiliar with stroke, the condition is such that you have some blockage in the brain or potentially a rupture, and time to treatment is critical. And it's the difference between full recovery and either severe impairment or death. So every minute counts, and you need to get this patient seen and treatment, the appropriate treatment started as quickly as possible. But what happens when somebody has a stroke and they're out in a rural part of the country, which a vast portion of our country is rural, and the local community hospital or critical access hospital has no neurologist on site? Basically, what they end up having to do is transport that patient to a facility that does have the expertise, which may be hours away, which, as I just established, is not good for somebody who's experienced stroke, right? The outcomes are really, really poor. So what are the options? Well, we can get the provider to see that patient, make an assessment, and set up a treatment plan with the patient in place in that existing hospital through telehealth effectively. And I'll give you a quick example of where we've done this. So Vanderbilt University Medical Center, they deliver their expertise to community hospitals, some of which are their own, some of which are third-party hospitals. We were able to, through the platform, connect the EHR, so their partner sites, with their EHR, so that those referring sites, when they have a patient present with stroke, we're able to place an order in their EHR. Same way they would if the neurologist was local, except it happens to be a telestroke order. We received that order, through the integration that we've done with their EHR. We generate the patient, we generate the encounter, and then we've integrated with Vanderbilt's notification platform, provider scheduling and notification platform, and keep track of whether or not that notification has been responded to, so that if it hasn't been responded to within the specified time frame, we're able to escalate and send different notification to the backup or to an administrator, whatever the case is, to make sure that, somebody is jumping on to get this patient the help that they need.
Wow.
And then the provider is able to go in. They can review the information that got pulled out of that EHR. So they've got full presentation on the patient right up front. They're able to click a button, start the video to the endpoint that's in front of the patient. It automatically answers on the other side. They're able to conduct that assessment of the patient and make an expert determination whether this is ischemic stroke that can be treated with thrombolytic, that's a clot buster medication, or a rupture, if you will, in the brain, and requiring endovascular treatment, whatever, surgery, whatever the case may be, and get that treatment started. And that has benefits for the patient, obviously, in terms of the outcomes. It has benefits for those community hospitals that work off of razor-thin margins. So if they have to send that patient out, they lose all the downstream revenue on that patient for everything that comes after. So by keeping them there, you're keeping that critical access hospital or community hospital more economically viable, which is really important to the community that they serve and such. And for the hospitals providing the consult, while providing the service isn't necessarily going to be a big revenue generator for them, what it does do is develops really strong relationships with these community hospitals that for the more complex cases that they can't treat locally, they will get the referral, which is, more significant revenue for them downstream and such. So it's really a win for everybody to provide that kind of service and access.
Yeah, that's a powerful story with the work you guys did at Vanderbilt with the telestroke. Well, a couple of things stood out to me. One, from the story of ViTel Net, like it's clear you guys are veterans in this space, all the way from your days doing just RPM to now growing to address what you call these working data flow challenges, and it's clear just in that telestroke story how you're able to connect through your platform different EHRs that they were using either through their partners or in-house, and then the scheduling piece of it is so important. Like getting the order in and like providing the scheduling like all in one workflow. I think that's the key, right?
Yeah, getting it out to the right provider who's on shifts and automating that process so you don't have time wasted with people making phone calls and having the whole chain involved. That was really important.
Right. And so it's clear, I mean, Vanderbilt, that's a big like academic medical center. It's clear you guys are working closely with these AMCs and like health systems. What are some of the common like working like data flow challenges that these like organizations face, not just like across care delivery, but like research, education, and what does it actually take to like improve those workflows at the end of the day?
Yeah, so that's a great question. I think what it boils down to is flexibility. If the tool or the platform prescribes how you have to practice, it limits what they're able to do in a research protocol, for example. So I'll give you another example. University of Miami, they were studying the impact of different rehab protocols on patients that had spinal cord injuries. And obviously with spinal cord injury, mobility is a challenge, and getting them to come to facility to do rehab and such is not a great situation for the patient. So they set up a program where they had a special bike that somebody in a wheelchair could roll up to in order to do exercise that we added our tech to in order to enable a remote care team that's multidisciplinary and in different locations to be able to monitor that patient while they were doing the exercise so that, number one, they could coach them through the exercise. Number two, they can monitor their vital signs so that if they're, we're getting out of appropriate range, they can back things off and make sure that, patient was safe through the protocol and such. And number three, be able to document, what patient was experiencing and such as part of their research. Now, when we first engaged with the university, they told us that they were looking to do remote patient monitoring. And we said, oh yeah, we know what remote patient monitoring is. And then we got deeper into the requirements of what they were actually looking to do. And it was not what everybody in the industry refers to as remote patient monitoring. This was just real-time viewing of the blood pressure, SpO2 and such, and being able to capture that and see that remotely. That didn't exist in the market at the time. So we built the capability to do that in real time as part of the platform, and we configured a web application that matched their research protocol so that they were able to manage, each of those cases fully inside of the platform and be able to, do this at a distance to support the needs of those patients and the needs of their research.
Wow, another fascinating story in the rehab space, specifically with spinal cord injuries. It's interesting you said like they thought they wanted RPM, but when you dug into the requirements, it was actually not that. It was something different, and you guys were able to really build that capability for them so that they could see the impact of those rehab protocols in real time.
Yeah, exactly right.
And I know you and I, like, we started to speak about this, but, a lot of healthcare organizations, health systems out there aren't looking for like standalone products of virtual care or telehealth, right? These are technologies that have been around for a while. They don't want to, or worse, rip and replace what they already have, How do you guys mold around like what's already in place and plug into like different EHRs and different point solutions that these AMCs and health systems have?
Yeah, it's a great point, Bert. The key here is that, as you know, virtual care lived as point solutions for many, many years up until COVID-19. COVID-19 is what woke up the healthcare industry to say, hey, this is a viable way of delivering care, and we need to be able to scale it. And you can't do that as a point solution that's separate from everything else that you do. You really need to have a hybrid care model where there are times when it's appropriate to deliver in person, and there's times when it's appropriate to deliver virtually. And you just need to have the option to do whatever is most appropriate for the patient in the given circumstance. For that to happen, and to happen efficiently, and in a manner that providers always armed with the best information and data to make good decisions for those patients, that means that your back-end health IT infrastructure has to be fully integrated. Otherwise, you're going to have disparities and gaps in information with regard to that patient, which can be dangerous for the patient and doesn't end up in optimal results. So yeah, tying together the back end is really key. And like you said, every health system has something deployed today, and some of it works for them. Some of it doesn't. Some of it's just gaps that they have where they've got, 3 different pieces, but they have no way to tie them together. Our approach to that has been modular design. So we designed the platform to be modular from the ground up, so that we could see what was working within the health system. And instead of, like you said, rip and replace, we can go ahead and plug in the parts that are missing, integrated with what they've already got, so that you end up with a good, coherent, very efficient workflow that the data gets to where it needs to be and enables providers to be just as effective remotely as they are in person.
Yeah, right on. Yeah, I mean, that it sounds like what really distinguishes your approach is this modular design, and like I think there's a big, probably, I don't know if it's a misconception in the industry that like virtual care is just all front end, it's like what the patient sees, and it's probably like 50% or less of the equation. The other 50% is the whole back end infrastructure. Like is that in a place where they want it to be? And oftentimes they answer it for you is probably no, from what you've seen. Like they require a lot of support there, and so you guys have truly built this like modular, like no code platform almost, that supports and all types of integrations across different environments, telestroke, rehab, right?
Yeah.
Where do you see like this your virtual care platform and this technology heading next in the industry?
So we know that the platform is wholly use case independent, right? And we support behavioral health, we support cardiology, we support MFM, all kinds of different use cases. It doesn't matter because of the flexibility and the workflow and such. Where we're going with it is continuing to break down barriers to access. We will continue to drive on making providers more efficient. From that perspective, you'll see more coming from us with the integration of some of the awesome AI tools that have entered the market space, and obviously lots of buzz around them right now. we look at it wholly from the perspective of how can we use these tools to make these providers more efficient, help with some of the staffing shortages that exist and such by making them more efficient and end up delivering better care. An example of that, right now we're in a pilot with UVA, the University of Virginia. They also have a telestroke program, and there we're integrating an AI agent that we are pulling information from their EHR. We're combining that with data that got entered into our system as part of the stroke and feeding that as a patient presentation to the AI agent. And then we're asking it some basic questions that every neurologist is going to want to know going into one of these stroke encounters. What are the risk factors for this patient? What are the contraindications? Are they thrombolytic eligible? Is it endovascular treatment eligible? And the AI agent will respond with visibility for the provider in terms of what information was available and fed to the AI that led to the response, so they can see if something key was missing from it. They can go ahead and refresh, because with stroke, information shows up as you're doing the treatment, but they can refresh, resend, and get an updated response from the AI as a result. They can then go ahead and edit that response. So if they don't, they're not comfortable with what's there, they can edit it. There's also links so that they can find out, drill into, how did the AI come up with this, right? So if there's something that they're not sure of or not confident in, they can actually drill into it to understand. So it's not a black box like a lot of the other AI technologies that we've seen, which is one of the things we really liked about this approach. And with that, the provider then is able to click a button and add that either straight out of the box or edited information into the note. So we've saved them time from not having to mine through the record. We've saved them time in terms of documentation and generating it. And then at the end, once they're ready to do diagnosis and treatment, we will refresh back to AI and have AI come back with differential diagnosis and most likely treatment plan, so that, again, the provider can go ahead and review, edit, and just add to the note. Overall, significantly improving the efficiency of the provider.
Yeah, no joke. I mean, how many companies out there can say they're already integrating AI agents into telestroke programs? Not many. I think that's very cutting edge, and sounds like it'll be a successful pilot when it's all said and done. And with that in mind, what do you think, Mark, holds back these academic medical centers and health systems from really addressing these working data flow challenges? Is it just lack of education in the market? Hey, there's partners like you guys that are not just the technology, but are the integrators? Is it finding the downtime for all the clinical staff and operational staff involved? What is it what prevents them from really addressing this, in your eyes?
Yeah, it's a great question, Bert. There's no one single cause. It varies by organization. In a lot of cases, it's just priorities. Right? These teams are dealing with so much. There's so much change and uncertainty right now that it's a real challenge for, folks who are commissioned with the health informatics and IT component of these health systems. They've just got a tremendous amount on their plates. And most of the time, the bulk of their focus ends up being on whatever's going on with the EHR. Right. And you got things like, for example, with Oracle announcing, the launch of a brand new EHR that is not upgradable, if you will, from the current products that's in the market. Yeah. You've got a whole market now, healthcare systems that are on the precipice of a major EHR change. Whether they move forward to the next version that Oracle is providing or they jump to another vendor. In either case, that is a significantly disruptive event for a healthcare system. We try to help those folks by providing a middleware layer, if you will, that will extract the workflows for the clinicians from the EHR so that when they do that backend switch, that can become fully transparent for the end users. Because that's usually where you end up with the disruption, right? The end users end up having to relearn how to do things because the new tool is a completely different workflow from the old tool and such. Things are in different places, and people are very confused. So what we end up doing is we configure a web application that matches the workflows that they're used to, or help tweak it to whatever it is that they want to get to. That helps to minimize the change management piece, have that integrated with their existing EHR. And then as they migrate to the new EHR, we will integrate with the new EHR as well, so that switchover is completely transparent to the end users. And the whole care delivery process remains untouched effectively. So that's what we're looking to do to help the folks in the transition states for the Cerner-based stuff.
Yeah.
And outside of that, it's changes in the regulatory environments and understanding where things are going from a reimbursement perspective, because that has total impact on their business models, right?
Right.
Hard to figure out what your ROI is going to be if you're not sure what the revenue side of it's going to look like, a year from now.
Right.
That's the other thing that ends up causing people to drag their feet a bit when they're trying to figure out where to go next.
Right. Yeah. I mean, with that, with Oracle's announcement, I think that'll really probably open up a lot of opportunities for you guys in the sense of like organizations that need support with that middleware, or like a lot of these complex integrations as they migrate EHRs. Maybe you've seen this in your line of work. Laco understand that there is like some reimbursement incentives. I know we talked about referrals earlier, but for like these virtual care telehealth technologies, like yes, they're not all encompassing, but if done the right way, I think these academic medical centers and health systems can also there's certain CPT codes is what I'm trying to get after, for these technologies. And I imagine as this space evolves further, there's going to be more regulatory acknowledgement of that and opening for new reimbursement incentives, because we're on this path. Like another thing that comes to mind, I don't know if you guys touched this, is the whole virtual nursing piece, right? Like there's a huge shortage of nurses across the country, and a lot of organizations are investing into virtual nursing, so.
Yeah. And virtual nursing is going to be critical for the affordability of healthcare. Like you said, with the severe shortage that's there and the rapidly escalating cost associated with nursing as a result, they have to figure out virtual nursing.
100%. Yeah.
And that again requires integration with the backend health IT infrastructure if they're going to be effective remotely for virtual. And there's also a whole suite of different workflows that need to be supported because of the breadth of what virtual nursing can mean and consume.
Yep.
It's everything from supporting codes with experts guidance to those on site, to admits and discharges and patient education and such, and responding to nurse call bells, and there's a whole wide range of things that need to be handled and addressed in that space.
Right, definitely. And on this point of a lot of this requires integration with backend infrastructure, like what is next for the ViTel Net team specifically? Like how can interested partners like health systems, AMC leaders listening to this get in touch with you guys and start to dig into this backend IT infrastructure and their workflow, their working data flow challenges, Yeah.
So there's lots of paths to get a hold of us. You can, obviously come in through our website at www.vitelnet.com. You can always reach out to me. I'm simply mnoble@vitelnet.com. We also have a general info email address, and certainly you can get us on LinkedIn. Just search for ViTel Net. You'll get to us. Those are all good paths to get a hold of us.
Yeah, spot on. All right. Yeah, we'll make sure to include those links, podcast description below, and in the post that'll follow this. Yeah, Mark, it was a pleasure speaking to you today. Excited to keep tabs on your guys' journey at ViTel Net. I'm sure there will be no short of supply of need or opportunity and need in this space, especially as our tech stacks in healthcare get more complex with data, right? Like the advent of AI is only bringing our ability to digest and do with data more and more. So I'm sure there will be more working data flow challenges that pop up, more EHR migrations and technology advances. So excited to keep tabs on your guys' journey, and thanks for hopping on the podcast today.
Thank you, Bert. Appreciate you having us on the show.
Thanks, Mark.